Thyroid neoplasms. Thyroid neoplasms is an important topic in surgery, both for practicing doctors as well as for undergraduates preparing for exams. Thyroid neoplasm is an important topic not only for theoretical exams but clinical exams as well for the undergraduate students. In this short overview, I will try to convey the clinical features, the investigations, and the latest treatment that are available for these malignant neoplasms of the thyroid. The thyroid gland is very important, especially to a surgeon, as the various operations done on the thyroid and the anterior part of the neck, it's very important to know the various structures that crisscross this area and come in close relationship with the thyroid. First, you have the blood supply. Okay, the superior pole is supplied by the superior thyroid artery, which is a branch of the external carotid. It descends downwards into the thyroid gland at the upper pole and sends its branches towards the isthmus. It is accompanied by the superior thyroid vein, which empties into the internal jugular. Okay, on the left side, it's the same, the superior laryngeal, superior thyroid artery and the superior thyroid vein. And the nerve that closely related runs together with the superior thyroid artery is the superior laryngeal nerve. Okay, that's the right and left superior laryngeal nerve. But over at the lower poles of the thyroid, the main supply is from the inferior thyroid artery, which is a branch of the thyrocervical trunk, which in turn comes from the right subclavian artery. Okay, so this lower lobe is closely related to the recurrent laryngeal nerve here and another recurrent laryngeal nerve on the left side. These recurrent laryngeal nerves branch from the left and right vagus nerves respectively. They curve around and enter posteriorly the tracheoesophageal groove and pass behind the lower lobe of the thyroid. So same here, the recurrent laryngeal nerve goes posteriorly into the tracheoesophageal groove that is behind the lower pole of the thyroid. Inferior thyroid veins drain into the brachiocephalic trunk on the brachiocephalic vein on the right side and the left side. This slide shows the thyroid physiology that takes place in the follicular cells of the thyroid, which line the colloid field follicles. It's a single layer of cells here, epithelial cells known as the follicular cells. Okay, so this is what happens in the follicular cell, and this is the colloid. Iodine from the blood is taken up into the colloid cells, the follicular cells, in the iodine sodium pump. It exchanges sodium for every iodine that is taken in. This iodine is taken into the follicular cells, then excreted into the colloid where it is oxidized. At the same time, the follicular cells secrete thyroglobulin, they synthesize and secrete thyroglobulin, which is excreted by exocytosis into the colloid of the follicles. Okay, and this thyroglobulin combines with the oxidized iodine is conjugated, and it is formed. The conjugated iodine thyroglobulin molecule is then re-enters by exocytosis into the follicular cells, where it is combined with thyroxine, is produced, it is converted to thyroxine T4 and triiodothyronine T3 and re-excreted back into the blood. For this function, the all important thyroid stimulating hormone, or TSH, from the anterior pituitary is very important. It stimulates the follicular cells of the thyroid to take up the iodine and use it to synthesize the thyroid hormones and subsequently secrete these hormones back into the blood. So because of this stimulation of the TSH, we have T4 and T3, which are secreted into the blood, and these hormones are involved in the metabolism, growth, and maturation of all the tissues in the body. First, the classification of thyroid neoplasms. Okay, thyroid neoplasms can be classified according to this chart here into benign and malignant. And benign consists of the follicular adenomas, the Erdl cell adenomas, and the colloid adenomas, among which the most common is the colloid adenomas, the simple colloid adenomas, which are benign. We shall not deal with the benign lesions today, and we'll go to the malignant side. This is the Dunhill classification into differentiated and after undifferentiated neoplasms. The differentiated tumors are the papillary carcinoma, which form about 80%, follicular carcinoma 10%, Erdl cell carcinoma 3%, and papillocarcinoma. These are the four types of differentiated malignancies of the thyroid. Under the undifferentiated, these are the most important is your anaplastic carcinoma, which consists of about 1 to 2%, medullary carcinoma 5 to 10%, malignant lymphomas less than 1%, and secondaries from the colon, kidney, and melanoma. This again another presentation of the types of malignant neoplasms of the thyroid. Most common, papillary, follicular, medullary from the C cells or the parafollicular cells of the thyroid, anaplastic, and others such as the Erdl cell carcinoma. Then they also have lymphomas, primary lymphomas originating from the lymphoid tissue within the thyroid, and metastatic cancers from secondaries from other places. Next, we come to the clinical features of the thyroid tumors. First, the symptoms. The majority of patients come complaining of a swelling or a lump in the neck, either in the front of the leg or by the side of the neck. So it is utmost for us to get the details of the swelling or the lump. Okay, its origin, onset, progress, whether it's associated with pain. These are all important parameters that we must look for. Then the pressure symptoms due to the swelling or the lump, which is 3 of them: hoarseness of the voice due to pressure on the recurrent laryngeal nerve, dysphagia due to pressure on the esophagus,
and stridor, which is a late symptom due to pressure on the trachea, which the thyroid lobes straddle. Hypo and hyperfunction symptoms are rarely encountered in malignant lesions of the thyroid. As for the signs, again, a lump is the most commonly noted sign, which is usually a solitary nodule. Occasionally, there can be more than a nodule. Again, as in the history, it is important to determine the certain features of this lump which will suggest it is malignant. The mobility and the fixity of this lump. Malignant lesions can tend to be fixed, whether it moves with swallowing, the consistency. Malignant nodules tend to be hard, and also the associated lymph nodes in malignant nodules. Next, investigations to be done for thyroid cancers. First, thyroid function test, which includes T3, T4, and TSH. This, in malignant lesions, most of the time, majority of malignant cases, they will be normal, within normal limits. Then, thyroglobulin can be assessed. The serum level of thyroglobulin is a good serum marker, especially for monitoring the patient after surgery. Ultrasound scan of the thyroid is very, very useful in diagnosing early lumps which may be malignant. Next is the fine needle aspiration cytology, or FNAC, which has become very essential and compulsory in most cases for making a diagnosis, whether it is malignant or otherwise. And CT scan can be occasionally used, especially in anaplastic cancers, which tend to be very aggressive and invasive locally. So these can be useful to detect the operability of the patient with anaplastic cancers. The staging of thyroid cancers by the TNM criteria is a very good classification. Okay. Stage 1 refers to less than 2 centimeter in diameter. The tumor is less than 2 centimeters in diameter without evidence of disease outside the thyroid gland. That means less than 2 centimeters confined within the thyroid gland. Stage 2, tumor is 2 to 4 centimeters, again without evidence of extrathyroidal disease. Stage 3, the tumor is greater than 4 centimeters or level 6 nodal metastasis or microscopic extrathyroidal invasion regardless of tumor size. And stage 4, any distant metastasis or lymph node involvement outside the level 6 or gross soft tissue extension. Okay. Treatment of thyroid cancers again can be divided into a number of phases here. Initially, medical treatment is the main treatment which must be started early. The use of suppressive doses of thyroxine to suppress the TSH and further stimulation of the thyroid. Usually we give them double the usual dose of thyroxine. Next, radioiodine has a different role, especially in cases where you can say they are aggressive tumors. So you have radioiodine, or in patients where it has grown outside the thyroid, invaded the thyroid, extrathyroid tissue. So these are places where radioiodine will be very useful. Another place for radioiodine is recurrence after surgery. Then thirdly is surgery, the various types of thyroidectomy. Okay, you have a lobectomy, you have a subtotal thyroidectomy, and total thyroidectomy. These are the three main types. Then coming to serum markers, thyroglobulin is a very useful tool to monitor the patient after the operation for the possibility of recurrence. These are the types of thyroidectomies which we have commonly done. First, total thyroidectomy, complete removal of all visible thyroid tissue. So there is no confusion over this total thyroidectomy. Next, near total thyroidectomy is complete dissection on one side, leaving a remnant of thyroid tissue laterally on the contralateral side. So this is known as near total thyroidectomy. Third, subtotal thyroidectomy, or STT it is called, leaves a rim of thyroid tissue on both lobes bilaterally. And fourth, hemithyroidectomy, where one lobe with the isthmus is removed. This is the minimal operation for the thyroid, and this is also known as lobectomy. To make it simpler, I tend to classify the types of thyroid surgery into three main types to make it simpler. First is your thyroid lobectomy. It's generally performed when tumor is restricted to one lobe of the thyroid gland and has not yet started invading the other organs or lymph nodes. So you remove the thyroid of the affected lobe with the isthmus. This is lobectomy. Then subtotal thyroidectomy, or STT, is the procedure when most of the gland is removed, but a small portion is left behind as well. So you see, most of the thyroid, the white part, is removed, leaving behind a thin ring of thyroid tissue on one side. Some people prefer to leave some tissue at the apex on both sides, whereby the parathyroids are spared. And then the third type is total thyroidectomy, which is quite easy. When the entire gland is removed, the procedure is also known as total thyroidectomy. Okay, so this is the entire gland. So this is a simplified version of remembering what the type of thyroidectomies have been used to describe the various procedures. Coming to prognosis, three important factors must be taken into consideration. Most thyroid cancers are very curable as compared to other cancers. That is the number one consideration. Secondly, the most common types of thyroid cancer, that is the papillary and follicular, are the most curable among the cancers. Okay? And thirdly, in younger patients, especially those less than 50 years of age, both papillary and follicular cancers have a more than 98% cure rate if treated appropriately. So, it is very important to detect the patient early and treat them aggressively so that you can get a cure of 98%. If you're talking of cure rate, not 5-year survival rate. In fact, for papillary tumors, we can talk of cure rate, not 5-year survival rate. So it is a curable condition which must be treated aggressively. This table shows you the prognosis rate in figures. Papillary carcinoma as high as 93%. In fact, now people consider as even 98% long-term survival rate. Follicular carcinoma, 94% long-term survival rate. Hurthle cell carcinoma, which is a malignant form of aggressive form of follicular carcinoma, the rate can go up to 20% mortality rate of 10 years. And medullary carcinoma, what, 80% 10-year survival rate with 40%, 45% with lymph node involvement. So you can see from here, both papillary and follicular carcinoma, which account for about 90% of the thyroid cancers, have got very good cure rates. This usually affect the younger patients, and there's a very good potential for cure. Therefore, the traditional or the conventional treatment was to go for very aggressive treatment and then hope for the cure. However, we know that the thyroid cancers are slow-growing tumors, and we can now classify them as low and high risk depending on the size of the tumor. Less than 1 cm, low risk. More than 1 cm and high risk. As long as it's less than a cm, confined to within the thyroid tissue or thyroid gland, it's considered low risk. Therefore, there is a new trend or some new thinking on the treatment. It says that we continue to be more conservative in our treatment of thyroid cancers, especially papillary and follicular tumors, because the consequences may not be that dire as we believe to be. The art of medicine consists in amusing the patient while nature cures the disease. So I wonder, what is the role of the doctor? Thank you.